see a nurse do that before she inserts a urinal catheter. You'll see a respiratory therapist or even a nurse do that for sectioning of a trach. You'll see a physician do that for an HSG, hysterosalpingogram. Assisted gloving is a little different. This happens more in IR procedures than surgical. Again, notice how the hand is going in kind of very compact, no fingers spread, and the person holding the glove is already sterile and already has sterile gloves on themselves. So even removing sterile gloves, I should have done that better, sorry. You want to grab the sleeve part and pull down. You guys can kind of start doing this with regular gloves. And you just kind of roll them off your fingers. A lot of times I'll roll them together because anything on the outside of those gloves are now contaminated inside, and you roll them together. So let's talk a little bit about where you're going to use these sterile techniques. Dressing changes. You might see an interventional tech go up and do this. Sometimes nurses are doing this bedside over the chest tube. I was hoping we had like a chest tube monitor thing. Dressings are best changed in a team. A lot of times you have the physician and the nurse assisting. The physician is responsible for ordering the dressing changes to the reapplication. This is really a lot of nursing or like interventional techs. You might see surgery come up and change dressings before a patient is discharged. It's still a sterile technique. The patient should just be monitored and made comfortable while this is happening. You got to explain what you're doing to the patient. You don't want them moving a whole lot, especially if there's sterile equipment laying around, say like they have hip dressing that they're removing and replacing before the patient's discharged. You don't want the patient moving their leg and swinging into the sterile equipment. Never, ever, ever touch dressing with bare hands. All right, make sure you have gloves on. You should wash your hands before touching any dressing. You should wash your hands before you put gloves on. Sorry, this is just telling you there's a lot of prep work. So you need to make sure that the sterile towels are set out, that you've got any kind of cleaning solution you need to clean the wound with is set aside, and that tape is set aside in the sterile field. We'll get on to the tracheostomy. Anybody seen a tracheostomy? Not an ET tube, but where they have it actually coming out of their throat. Yeah, they get pretty nasty. You might get a patient come down to you that needs it suctioned. You are not trained to suction them. Only nurses and respiratory therapists are trained to suction them. And again, it requires a sterile technique to suction them and special suctioning tube. You're making that face that I normally make when I see it happen because I just don't dispute them.
Oh, this
at all. Yeah. Yeah. So that's why I do not go into respiratory care. But make sure that you get someone that is appropriately trained to do this. It's very important to keep the airway open and unobstructed. So if you get a patient that's coughing a lot, or they're just really struggling and they have one of those, say you're in doing a portable x-ray, hit that call button for the nurse. A lot of times if you're in the ICU or something, those patients have respiratory care in there all the time, so they're circulating, they're not off the floor. So if you're concerned for your patient, just make sure you give them help. A lot of times these patients don't like having it in there. It's probably a new thing. They're probably very anxious. So just make sure that you're trying to communicate with them. A lot of times they're talking. You may not just be able to hear them, so just try to read their lips the best you can. if you notice that they're struggling, just get help, okay? But you should not be touching a tracheostomy at all. In the event that it comes out, grab someone immediately. Do not try to reinsert it. Okay? Chest tubes. We went over chest tubes just a little bit before. Chest tubes help to drain in your mediastinal and interpleural space. They can help remove extra air or fluid that should not be there. It can actually help create negative pressure. Anybody know what atelectasis is? A collapsed or partial lung. Anybody know what a pneumothorax is? Air in the lungs. Air in the lungs. Very good. Outside, right? Outside of the normal pleural cavity. What's hemothorax then? Blood in the lungs. And a pleural effusion? Fluid. Extra fluid in the lungs, right? So a lot of times after having a massive surgery like open heart, or say they've had an injury to their thoracic cavity, people tend to have pleural effusions. This is very common after open heart or after a massive heart attack. Their heart does not be pumping like it should, so they have extra fluid that needs to be removed. So, can you see the chest tube in this picture? Yep. Anybody not see it?
I think I did. Can you point it out?
Yeah, it's in the lower left. Right? Right here. And like this slide says, it can be as high as the fourth intercostal space. I've seen some, if they have something going on, that it's all the way up here in the apices. And it can be as low as the 8th rib. It tends to go in from the side. Sometimes you'll have a mediastinal line that goes right up the center. A lot of times those are post-open heart surgery patients. But the key is to be very, very aware that they have them, and that they have drain lines. Not all drain lines have this attached to it, okay? Some have just a little bulb, like a bulb syringe attached to the end. It might be underneath the covers, it might be underneath their gown, especially if they're like a post-thoracic cavity surgery. Just be aware if you're moving lines, you're not grabbing things real harsh, moving them to the side. If you see this contraption at the end of the patient's bed or on the floor next to their bed, don't run over it with a portable machine, please. It's very, very messy. But there's different lines within this for suction, for taking the fluid off of the lungs. They all have a different role on the meter itself. Sometimes these patients have to be on continuous suction as well, so they might come down with a portable suction machine if they're actually coming down for like a tubing chest or something else. So be aware of that it keeps going. Urinary catheters. If you've had one, you understand what this is. Not super awesome. There are two ways that this can happen. It can be a straight type, or it can be a retention with a balloon. B is the retention with the balloon, you can see it there, and A is straight cathing. Some people have to straight cath themselves to even urinate, depending on if they've had radiation therapy down there and they just can't go to the bathroom anymore on their own. Some people have blockages or narrowing. So you might have a patient that has to straight cath themselves, and they take this everywhere with them. Catheters are sized in French. You'll have really, really tiny small French, like a 1 French. go in and inject contrast into the uterus and then into the fallopian tubes. That's why it's so tiny. So it's a really small French. What's that say? The French.
Oh, 5.
Yeah. So it's a 5. This is a little 5 French.
There, under the word use. With Sharpie.
Yeah. Urinary catheters, the French size is a little bit bigger than that. You definitely want that balloon inflated so it doesn't fall out during the procedure. And saline is what's in that balloon. Most of the time, you're not going to cath a patient, okay, unless you've had prior knowledge on how to do this or training. A lot of times you'll have your waiting room nurse, most places have it. If you have a procedure like a retrograde urethrogram or something, your waiting room nurse will insert this into a patient, okay? So anytime I say retrograde, it's basically sending contrast against the natural flow in that part of the body. So like a retrograde urethrogram would go all the way up the urethra, fill the bladder, and then you might have them void it out, so you're gonna watch them pee it out on x-ray. So Foley catheters have different purposes. You can empty the bladder, you can relieve bladder retention if the patient has not had a good urination in a couple days. For some reason, different pathologies cause you to retain your urine. Sometimes you can put a drug up through this to help the bladder. You can actually irrigate the bladder. Sometimes you'll have a catheter indwelling for some women that have maybe had a surgical robotic procedure for tube tied or some kind of gyno procedure, and they might have clipped the ureters or bladder, and so they want to make sure that it stays open. I know there was 2 circulating. Should be the same size, but I can't guarantee it.
They're not.
7.
One's 5, one's 7.
Okay. So, the point was that there's different sizes. You can get really big, huge French. Those tend to go into ostomy sites to check for your GI tract. But for the bladder, and specifically, you'll have a patient come in and they just want to make sure that nothing is open or clipped after surgery. So this patient may have a catheter, they're ready to get rid of it, and you might actually have to take it out after the procedure with the consent of the physician that's done it to make sure that, yes, the ureters are going to the bladder, nothing's leaking out, everything looks good. Okay? These are some reasons why a person would come in or need a catheter. Oh, sorry. This should be bolded and highlighted. If you empty the urine bag for some reason, if a poor patient comes down and they are full, and it needs to be emptied, let me set on the table. Please take a measurement and record it, because they might be recording the patient's output. Fixing yourself.
Yeah.
Lord, okay. So just make sure that you get the measurement before you empty the catheter bag. The nurse might be really upset with you if you do not. If you have a patient that needs to go pee in your x-ray room as well, hopefully they don't do it on the floor, but if they do it in a urinal, especially my male patients, make sure you record that, how much that is, before you toss it out, because again, they might be on Lasix and needing to gauge how much they have output-wise as far as urine. All right, indwelling catheters, the tip of the catheter lays in the urinary bladder. I feel like the next picture is a better demonstration of that, but if you turn to page 256, you can kind of follow along with what I'm saying. Catheter tubing should be taped to the inside of the leg. We have fancy things that has like looks like tape, and then it has a clip attached to it to hold that catheter line in place. Your catheter line is then attached to this fancy bag. Okay? Definitely 100% want to make sure that this is clamped off and closed, because if it is not, you're going to get pee, a little trail of pee from the patient's room down to your x-ray room and back, which happens. So, this is a catheter bag if you did not know. It's the drainage bag. See how it's calibrated, see how much is in there. This is what you need to keep lower than the patient's bladder, right? You don't want the dirty urine going back up in the bladder and causing infection. I think I said this before, that's where we learned about CAUTI, right? There's a lovely picture in your book. And notice that the bladder bag is lower than the actual bladder on the patient. If you have to move a patient like this, please be very mindful of where the line is, how much slack you have, where you put the bag, right? If you're rolling or moving a patient, a lot of times we'll put it down at their feet, which tends to be lower than their bladder. When you attach it back to a wheelchair, if the patient's gotten up and back in the wheelchair, make sure you're putting it free from where it can get caught in the wheels of the wheelchair. Yeah, not fun. So just be very mindful. If this is not properly taped to the leg, it can pull and hurt. Okay. All right, you might have to remove a urinary catheter. Make sure you wash your hands, put gloves on, that should be folded, red. Put gloves on. You're gonna appropriately uncover the patient. You might have to put a basin or something underneath this, but a lot of times this is disconnected from the actual tubing. I was hoping to find a catheter, but I couldn't find one, and there's nothing labeled back there in the storage closet. So you're gonna, where's my leg? Is there one still floating around? So these are very much like urinary catheters. There is a little tiny balloon at the tip here. Okay, and this is where that saline goes in. So what you're gonna do is you're gonna cut the tube that has the balloon inflated, right? It's gonna deflate that. You're gonna be able to gently pull the catheter out for a patient. If you get any resistance at all, stop. Don't keep going. Then you're gonna make sure you cover your patient and put everything in the trash and dispose of it properly. The patient will most likely be very, very pleased to have that thing out. Super uncomfortable, I've had one in my life. All right, let's talk about intravenous lines or arterial lines. You have to use a sterile technique for insertion of these type of lines. They're there for a bunch of different reasons. We've gone over the PICC line, the peripheral catheter line. A lot of times they're venous or arterial. You'll see these a lot in little babies in the umbilical cord area. A lot of times it requires imaging after they've been placed to see that they're in the correct position. A lot of times I'll look for which arm the PICC line is placed so I can note. A lot of times if it's the right, I'll put a right on my portable detector. So I remember that it was a right PICC line, because sometimes they have other lines going in from other areas, maybe from the left side of the neck. So I want to make sure that they're looking specifically at the right PICC line that I did. Permanent pacemakers, you will take x-rays for these from time to time. A lot of times they're looking to see where the line is. We don't place these in radiology, but you might be assisting them in like a surgical suite for placement of these. A lot of times they're done under fluoro with a post, like first day, second day, what should you not do? You're standing them up to do a 2-view chest, the patient's feeling great, what should you not do? What should you not do? Say, I just had a pacemaker placed yesterday morning. I'm coming down to you, I need a 2-view chest. I can jump out of that wheelchair, I'm feeling great. My left arm's a little sore, but
You're not gonna put it.
Keep something close by in case they need to catch themselves.
but specifically for chest x-rays, what should you not do? Go ahead.
Sorry, I keep interrupting you and other people. So you're not gonna put the left for magnification of the heart, you're not gonna put that pacemaker to the affected side, right?
No, you still are.
Are you really?
Yes,
Yeah.
you're not gonna raise their left arm up. So my pacemaker is on the left side, okay? You would normally have me just do like this for my lateral. You are not to move that left arm much. They are not to push up on the wheelchair with their left arm. They have explicit instructions that a lot of times they get from the cath lab or wherever unit they came from not to use that left arm. They might even come down to you in a sling, right? So yes, you are not to have them lift that left arm above their head. The most you should have them lift their left arm is like this, is I have them do this. Put it on their stomach, okay? All right, some things to keep in mind when you're going into surgery, portables and C-arms. Pay close attention to where the sterile technique is, if they're using sterile technique. There's times where you might have to go in and do a portable chest x-ray after something interventional. Make sure you ask ahead of time if the sterile field has been put up, right? Sometimes this is post, they might still be cleaning up. They might want you to still put a head wrap on or a bonnet on before you enter the room, as well as a mask. Sometimes these patients need a chest x-ray or something prior to, and the sterile tray is already open and exposed, so you will definitely have to be covered, yes.
So, portable x-ray situation that I encountered, just to be aware of your surroundings, and because I did a portable abdomen in the CCU,
What
and
is CCUs?
I don't remember, but we were doing an abdomen to check an NG tube replacement. The tech, it was a very small space, so
A lot of times they are.
the portable was like right by the door, and I was standing with my back against the door. The patient's daughter came up behind and took a picture of the x-ray on the portable machine.
Well, that's a no-no.
And we didn't know, like, I didn't realize it until like after it happened. And we had to fill out like a big old report about it and
Yeah.
all this stuff. So close doors if you can, be aware of your surroundings. That was a huge ordeal.
Well, in ICU too, because it sounds like that's an ICU situation. Kick them out.
Wouldn't you just ask them, hey, I don't want you to get exposed? And
Oh,
just
yeah,
come out for a
well,
minute?
she shouldn't have probably been lurking
Well,
by the door.
Well, yeah, it's,
So she probably should have just gone to the waiting
it was a
room.
very small room, so like the portable, like we pushed it as far as we could and moved what we could, but we like still had to extend the arm because the dude was in the chair, not the bed, and
Sure.
and so,
But that's not a sterile technique. An NG tube placement is not a sterile technique. However, be very aware of people that might be
yeah.
taking pictures, they cannot. This
Yeah.
happens a lot in ER to me. You'll ask family members to step out, those ER rooms are small. They might be lurking outside in the hallway because they're not gonna go all the way back to the waiting room.
That's exactly what had happened,
Yeah.
because it was like
But
right
in
inside
an
the door.
ICU situation, a lot of times the nurses are very good and will help you and
The
tell
nurse
you
will
to
stand-
send the patient out to the waiting, or the family member out to the waiting room. Okay, so, but in this case, they would have had to been very careful that they did not pull at or move anything where his NG tube was. When you're going into surgery and you're pushing the C-arm in, just be very aware of what's sterile, what's not, what's already draped. A lot of times they want us to just use a portable machine sometimes instead of a C-arm in surgery. So same thing applies, make sure your equipment is clean before you go in there, make sure you're careful of any sterile fields. The surgical team should actually drape your C-arm for you, especially anything that goes over the patient's body, right? Actual top of the C, that should all be draped with a sterile drape before it goes over the sterile field. And there's 3 different ways to drape a C-arm. A lot of times it's the top and the bottom that get draped, because sometimes you might move the C-arm to a lateral position, so both sides are on either side of the patient on the surgical table, so you want both of those draped. Sometimes you can drape the whole entire C shape. I think we need to take a field trip too, up to the surgical floor, so you guys can see some of this before. We might do that next week. So this is a common setup. You've got the C-arm kind of pushed in there. You don't even have a patient on there yet. A lot of times, depending on what surgery wants, they might have you go in before and set up, that you might come in as an afterthought once they get everything else set up. Depending on how busy the surgery is, depending on how much moving parts the surgery has. Orthopedic tends to be longer, have a lot more moving parts, a lot more equipment that needs to go in the room. But that doesn't leave you a lot of places to stand until you're really 100% sure. Stand back, right? Touch nothing blue. Taking actual x-rays in the operating room, make sure that you're wearing surgical scrubs, okay? Be aware of those sterile areas. Make sure you know who's doing what, kind of get an idea, who's floating, who's moving around. But know your equipment, be responsible for your equipment, that's very important. Know how to position your image receptor in the x-ray unit appropriately. Listen to where the surgeon wants you to go. I was not super successful in surgery because I have horrible hearing loss, and a lot of times there's noise, there's equipment noise in these rooms. The doctor's got nerve on, and a lot of times he's not talking, he's talking down into the patient's body, still working. So I was very unsuccessful in surgery as a surgical student because I could not hear, and I told my techs that. So a lot of times I'd get cues from my techs that I was working with to be like, hey, that's us, that's us. So when you'd have to make exposures and stuff. So make sure you can hear. If that's a problem, let your tech that you're working with in surgery know. If you really can't hear, like in my case. Sonography in surgery. We use sonography a lot in interventional. It's definitely helpful to see certain lines and vascular things that they might be doing in interventional. Again, these things still need to be covered. A lot of times any probes or wands that they use for ultrasound have to be covered with a sterile drape, and it's set to the side so only the doctor might use it, or the x-ray tech that's assisting the interventional doctor can touch it with their sterile gloves. And then there also needs to be like sterile ultrasound jelly that can't just come off the machine itself. So neonate portable x-rays. I've talked a little bit to you guys about some of this stuff. These babies are immune compromised because they don't have an immune system yet. So a lot of times you're protecting them from you. These nurses don't go anywhere else. They stay in the NICU, so a lot of times they're not wearing surgical scrubs. In certain cases, they might need to wear isolation gowns like this. Just be very careful when x-raying an infant. Make sure you wash your hands appropriately, have a mask on. If they've done a procedure like an umbilical line, you might see a doctor in there and they're wearing all sterile stuff, hat, mask, gloves, gown. A lot of times you'll need to go in with your hair covered, because again, your hair is a type of fomite. Carry something, could drop into the sterile field. And just take your time and be careful. A lot of times you're looking for babies that are tachypnic or have that respiratory distress syndrome or RDS. Anybody know who's more at risk for RDS? Boys or girls?
Isn't it boys?
Boys, small baby boys. They just don't come out learning how to breathe right. We still use gonadal shielding sometimes on little kiddos. It's not in the field of view. Sometimes you might need to take like what I call a chabdomen. This is a chest and abdomen, combine those two words, to get and make sure you've got like an atrial or a venous line all the way through, especially if it's going through the umbilical cord. So you won't throw a shield on those babies, because most likely they're covered in a sterile drape and everything is still open, okay? And then you can also use like a contact shield that goes over their little bassinets.
I have this really cool picture of me from, future, and they have the light shining with all the tubes and stuff, and you can literally like see through my skin. Like,
Yeah, because how big were you?
So paper thin. What?
How big were you?
Like 1 pound and a couple ounces.
Yeah, that's pretty
So I was
big.
like nothing, like gross. Like
The other thing about
It is.
NICU babies, a lot of times these bassinets that they're in are pretty high tech. If you don't know, just ask a nurse. They are hover, like talk about helicopter moms. These are helicopter nurses in the NICU, and rightfully so. Like their only task, and most of the time they have 1 to 2 babies. They don't have very many patients. It's just to make sure that this baby is getting better and leaving the NICU. So a lot of times these bassinets have little things that you can take the plexiglass side down, and there's a tray. And the tray is pretty awesome, because most of the time, the smallest detector on most of these digital portables, which I hope a lot of your machines have, the smallest detector, will slide in there and just slide right under. You don't have to pick the baby up, you don't have to get the nurse to pick the baby up and position them, because the less you can disturb them, especially if they have a lot of lines, the better. So utilize the equipment that you have. I know when you guys finally go to Children's, you'll see a pretty cool stuff there. My NICU at North Kansas City definitely has the trays, so utilize it the best you can. And then portable x-rays, when we're talking about asepsis and lines and stuff, just do your best to minimize how much you move the patient. Try and watch for those lines, right? Look for anything hanging off of the bed, especially chest tubes. Triage in the ER can be kind of chaotic, so if you're in the ER and you're doing portables, just be aware of everything hanging off the bed. And then use whatever protocol your hospital has in place for portables and going in. So when you need to, follow aseptic techniques to reduce the spread of harmful microorganisms. Remember that there's 2 different, there's medical and surgical. Sterile technique are required for proper gowning, glove, and mask practices. Anybody x-ray a COVID patient yet?
I got kicked out of a room.
Yeah, they don't let us. Really? We did.
Some places won't still let you. Did you go in the room?
Yeah.
Did you put gown, mask, face shield on?
No.
What did you wear?
Me neither. Mask, yeah.
Just a mask?
Yeah, same.
Just mask and glove, but I didn't touch the patient. I was like staying away from the patient. They come in the X-ray. It was
Okay,
not
so it was a
for-
walkie-talkie, you didn't go into an inpatient room?
No.
Okay. So when you go into an inpatient room that's in isolation, just be very aware, kind of use similar techniques like with degloving, that you pull the dirty gown away from you, right? Take your mask off very last, outside of the room, foam your hands, and then take it off. Don't touch your mask yet with dirty hands, because you're considered dirty when you walk out, so you gotta wash those hands with the foam. As always, always, guys, be aware of lines, if the patient's had a recent pacemaker, if they've got a catheter in. And then being proficient in aseptic technique is very important as a professional x-ray tech. And one last thing to show you.
Okay.
So, somebody said they've seen a surgeon right now. No, Patty hasn't. Dominic did. Who else said they saw an arch room? Okay, did it look something like this? Was this out on the? Okay. Oh, HSD is pretty cool. Super cool for the patient, but, alright, so here is a closed, you all can look this way and get off of your phones, please. Thank you. I get very crappy very often, but that really pisses me off. Okay? You're getting out of class early. I just have one last thing to show you. Yeah. This is a already opened, okay? You might have to eventually do this for a procedure or to help the tech. The tech might say, okay, there's an arthrogram tray in there, I'm gonna need you to open it. You go, what? So, this is a closed one. I'm not gonna open it to waste it. But, there's little instructions here on how to open that, right? So open it, and shuffle it out. A lot of times there's like a Mayo stand or a designated procedure table that you would do. Shuffle that out. This is kind of put back together. So I'm gonna turn it. This is all unsterile on the outside. Okay? I'm gonna do this. This. Someone grab me gauze. I got gauze. It's gonna demonstrate how you dump something on a tray. So if I then put on sterile gloves and kind of set this up and got things off of here, my hands are sterile now, and kind of set things out for the doctor, make sure, double check, everything is on his tray, that he can numb up the patient with lidocaine. So who would like to demonstrate dropping this on the tray? Okay, so take a sterile gauze, I'm still sterile. Come around the front. So, you washed your hands. You've got gloves on. So, you're going to open that. Nope. So, there is, on most of these things.
Oh, I see.
Yeah, so you're not just gonna rip, right?
Okay.
So, she's gonna start to open a little. Yeah. Now, what you're gonna do is not from behind, not too close, you're gonna gently try and stick it just on a plastic tray. Just higher. Yep, and now open. And drop. Okay? She didn't go across, right? She came as close as she could helpful and it's